All right, let's kick this off. Good morning to everybody on the webcast. I would like to welcome you to our celiac disease roundtable today. During the next approximately 1 hour, our experts will discuss why celiac disease is a serious lifelong autoimmune disorder and why there is a huge unmet medical need for new treatment options. My name is Jessica Brew, Head of Investor Relations and Communications at Immunic. I will also be the moderator on today's webcast. Please note that all participants will be in listen-only mode and this event is being recorded. After the expert discussion, you will also have an opportunity to ask questions. But let me first introduce today's experts. We are very excited to have 3 renowned thought leaders in the area of celiac disease joining us. We warmly welcome Dr. Ciarán Kelly from the Harvard Medical School in Boston, Dr. Joseph Murray from the Mayo Clinic in Rochester, Minnesota, and Marilyn from the Celiac Disease Foundation. From Immunic, we have our Chief Medical Officer, Dr. Andreas Müller, on the line. Thank you very much to all our experts for being with us today. Before we jump into celiac disease, let's briefly walk through the disclosures. Oh, not moving. 1 second. Here we go. Firstly, please consider Immunic's forward-looking statements shown on this slide. Secondly, please also consider the disclosures of our 3 external experts who receive compensation for today's event displayed on this slide. All right, now we stop sharing so you can see us even better and we can kick off the discussion. To start, Dr. Murray, can you please walk us through how common celiac disease actually is and also put this a little bit into context with other diseases such as multiple sclerosis?
Well, thank you, Jessica. So the celiac disease is one of the most common chronic autoimmune diseases affecting people of all ages. It affects probably at least 1% of the population. The rates have been increasing fairly dramatically over the last 3 decades and continue to increase, especially in young patients. And there are some locations where perhaps as many as 2.5% to 3% of adolescents may have developed or may be developing celiac disease. It's probably at least 3 times as common as the conditions like multiple sclerosis that are perhaps better known. It is as common as Crohn's disease and ulcerative colitis combined, 2 very common chronic inflammatory bowel diseases. So it's quite a common disorder.
Thank you. Yeah, the typical celiac disease symptoms, such as abdominal pain, nausea, diarrhea, or fatigue, don't sound too disturbing, and celiac disease is often casually assessed to be similar to food sensitivity. It is generally often overseen that celiac disease is a serious autoimmune disease leading to significant complications, and that celiac disease patients have serious limitations to live a normal social or work life. Dr. Kelly, could you please share some cases from your patients and experience what kind of complications and challenges for their everyday life can occur?
Well, there's a wide spectrum in terms of the type and severity of symptoms that patients with celiac disease will experience. It is true to say that some patients have relatively mild symptoms, and nonetheless, those symptoms are bothersome to those patients. But there is a significant proportion of patients who have more severe symptoms. And one of the symptoms that bother patients substantially is diarrhea. And certainly severe diarrhea can be incapacitating, can prevent the patient from work and social activities. Also, celiac disease is not only associated with symptoms, it's also associated with weight loss and malabsorption. And this malabsorption can lead to nutritional deficiencies. Common nutritional deficiencies in celiac disease would include iron deficiency, which can lead to anemia, vitamin D deficiency, which can lead to impaired bone health, and vitamin deficiencies, including vitamin B12 deficiency, which can lead to neurologic complications. And certainly these symptoms and manifestations can impair the patient's quality of life. Some patients will have very severe reactions to gluten exposures. And these gluten reactions can cause incapacitating nausea, vomiting, and diarrhea, and prevent the patient from working or even leaving the house for several days. There is also a condition called refractory celiac disease, where the disease does not respond to treatment with the gluten-free diet. And these signs and symptoms of refractory celiac disease are especially severe. And those patients will have incapacitating diarrhea and weight loss. And this condition can also be complicated by the development of intestinal lymphoma, which is often fatal.
Yeah, thank you for sharing these insights. Dr. Murray, the general population and sometimes even healthcare providers are often somewhat ignorant and assume that celiac disease patients do fine when just eating gluten-free. It was eye-opening to actually see a large survey with more than 7,000 patients that more than 40% of celiac patients have ongoing symptoms or lack of mucosal healing despite being on a gluten-free diet. Could you elaborate on the reasons for this, please? And why does this involve so many patients?
Well, I suppose in a way I have a confession. I've been looking after patients with celiac disease for over 35 years. And for most of those years, I thought once we made the diagnosis, sent them to the dietitian, that they went along their merry way and did okay. However, it took patients to tell us that, no, that's not the case. And of course, as physicians looking after patients with celiac disease, if they came back to us and complained about symptoms, as Dr. Kelly has just described, often very impactful on their health, the first place we went to was, well, what about your diet? And sent them back to the dietitian. And of course, these patients are already doing their best on a gluten-free diet, but continuing to suffer. And many of them were suffering in silence. And it took our patients and our patient advocacy groups to really tell us what real life was for patients with treated celiac disease. And I think in the last 10 to 15 years, it has become much more appreciated that a substantial number of patients continue to have substantial health problems despite doing their best on a gluten-free diet. And of course, the rest of the patients are bearing the entire burden of their treatment. So in a way, they'd almost been medically orphaned. So I think there was a lack of appreciation among the medical community of the seriousness of the condition of what we thought was treated celiac disease. It may be a treatment that helps and that works, but it doesn't work in a lot of patients. It's not effective in real life. And those are issues I know we're going to discuss later.
Yeah, thank you.
I would totally agree with Dr. Murray. There's a huge burden of treatment in following the gluten-free diet, and we'll be discussing that, I think, in a short while. But not only that, it doesn't always work. And I think there's a lack of appreciation for the fact that the intent to treat celiac disease with a gluten-free diet is not actually effective in many, many cases. And even when it is effective, the burden of treatment, as Dr. Murray mentioned, is very high. In other words, it's very difficult, if not impossible, to achieve an absolutely strict gluten-free diet. Unfortunately, when we're managing and looking after these patients at present, we have little else to offer.
Indeed, yeah. Maybe that's a good bridge to Marilyn. Marilyn, if you talk to someone about celiac disease for the first time, often their reaction is, at least from my experience, don't these patients just eat gluten-free and they are fine? What are the typical reactions you get in your daily experience? Oh, you're on mute, Marilyn.
You would think by now. So in the last few years, it's been encouraging in that usually when you talk to somebody about celiac disease, their first reaction now is, oh, wait, I know somebody who has that. More than a few years ago, people would have no idea what celiac disease was. So that's very encouraging. But you're right. Then the next thing is, oh, isn't that the thing where you can't eat gluten? And so the perception is still that it's just a dietary issue, that it's not a chronic, serious medical disease. Echoing what Dr. Murray and Dr. Kelly said, it's an echo trickle down from the physicians. So yes, complete understanding that, what gluten is, and gluten is something you don't eat, but no recognition that this is a true disease.
Yeah, maybe a follow-up question here. I would assume that celiac disease patients know very well which food is gluten-free and which not, We can only imagine how stressful it must be to be able to eat certain food, maybe some food that you, to don't eat certain food, sorry, maybe food that you even like. Can you describe how difficult it is for patients, and if there is a social outcast component as well?
Well, first of all, it's not easy to know what is gluten-free and what is not. And there's basic things like, when you first go on a gluten-free diet and you're told that you can't eat, soy sauce because soy sauce has wheat protein in it. And then you can't have barbecue sauce, American, because barbecue sauce has soy sauce in it. So there's all of these intricacies of what actually has the gluten protein in it and what you can eat and not. You go to a restaurant and the menu says it's labeled gluten-free. Well, maybe those ingredients were prepared gluten-free, but they've come into cross contact with gluten in the kitchen. So it's a very difficult thing to ascertain if something is actually gluten-free. And yeah, there's absolutely a social outcast, piece of it, because a lot of people will choose not to eat. They'll choose to skip social functions. They'll choose to skip family functions because the difficulty of not getting ill while they're eating is so great. The burden is so high.
Yeah, indeed.
I think that there's also a substantial fear of gluten exposure amongst patients with celiac disease. There's the practical issue of avoiding gluten, but there's also the continuous strain and stress of trying to plan one's menu so that each and every meal and snack throughout the day is gluten-free. And that causes a practical burden, but it also causes a mental burden for patients.
Yeah, thank you. Thank you both. This partially answered my next question already, actually, how difficult it actually is to follow a gluten-free diet. Maybe you can summarize once again, Marilyn.
Well, I'll echo Dr. Kelly. Absolutely that fear of every bite that goes into your mouth, that absolute planning. Are you going to bring your lunch? What if people are going out to lunch? The grocery shopping, the travel, every bit of it is full of fear of becoming ill.
Yeah, indeed.
And I would say that in addition to that, when we compare this to other diseases that we deal with medically, very few, if any, diseases have the same level of burden. The entire burden of treatment is on the patient and their family. It is, if you think about every time you do anything that involves or could involve food, social occasions, meals, shopping, travel, work events, etc. The casual nature with which we will taste things can never be casual for a patient with celiac disease, or it is fraught with danger. And when we think about even what I would regard as diseases with much less of an impact than celiac disease, we have treatments. We have things that can help people live with their diseases better. We have not yet provided anything for patients with celiac disease beyond the gluten-free diet.
As an illustration of how difficult it is to avoid gluten, we did a study recently of patients with established celiac disease who appeared to be doing well in avoiding gluten in their diet, but we carefully evaluated the presence of gluten in their food and in their stool over a period of 10 days. And over those 10 days, 2/3 of the patients in our study, and these are very, very fastidious patients involved in a clinical study. So they would, you imagine, be at their peak in terms of gluten avoidance. Nonetheless, 2/3 demonstrated evidence of exposure to gluten during just a 10-day period. And so the gluten-free diet, it may not be an easily achievable goal.
I'll add, in terms of university, which is extremely competitive in the US to get in, as is worldwide, decisions are made on whether the student can eat safely. And we have students who've actually had to leave very prestigious programs because they've become so ill because the program cannot accommodate a gluten-free diet that's safe from cross-contact with gluten. So entire career decisions are being made on whether or not you can eat safely.
Wow. So we touched a little bit on the social stigma already, but maybe a follow-up question here as well. Given that gluten-free diet is such a prominent cultural phenomenon, do patients suffer from social stigma when they request gluten-free food? Marilyn, maybe you can start.
So the answer is absolutely yes. And what I don't understand is we don't shame people who are diabetic who need to count their carbs. We even have friends and family who have high cholesterol And when they say they can't eat red meat, we don't make fun of them. How has it become that people with celiac disease who need to avoid gluten have become the scapegoat and the punchline in jokes? It doesn't make sense.
I think there's also a cultural phenomenon whereby some individuals are gluten-free by choice because they feel that is good for them. Whereas patients with celiac disease are not gluten-free by choice. They're gluten-free out of medical necessity. And so it's a much more serious commitment on their part. But these two phenomena sometimes can cause confusion as regards the degree to which somebody must be and their food must be gluten-free. For example, restaurant workers, kitchens in restaurants may not always appreciate the fact that somebody who has verified celiac disease and is on an absolutely strict gluten-free diet, that their food must be prepared in such a way as to avoid contamination by gluten. And that's not always the case. So this causes concern and problems for patients when they eat and they get a contaminated plate in a restaurant.
Mm-hmm. Yeah, Dr. Kelly, you touched on the treatment of celiac patients already. Maybe we continue here, given there is currently no approved treatment for celiac disease other than maintaining a gluten-free diet. What are you currently doing to support patients with ongoing active celiac disease, and what limitations do you see in helping these patients?
Well, as Dr. Murray mentioned earlier, our primary intervention is to encourage them to adhere to a strictly gluten-free diet and to provide them with educational resources from ourselves, but also from an expert celiac dietitian who can advise them as regards behaviors that are more likely to lead to gluten exposures. And this typically involves eating outside the home. Of course, the patient's kitchen and their food preparation at home has to be carefully evaluated. But when they're eating outside their home, they're no longer in charge and no longer in control of what arrives in front of them for their meal. And so we advise them as regards sort of trying to achieve safe practices in that regard. That's not always effective. And we do have some patients with continued active celiac disease, continued signs and symptoms, despite everyone's best efforts to avoid gluten in the diet. And for those individuals, we will sometimes use a steroid preparation, for example, enteric-coated budesonide, to try and reduce the gluten reactions in those patients. There isn't
I would add to that.
It's not an approved treatment, but it's something that we use in severe cases.
And in addition, many patients are using what we call symptomatic treatment. If they're getting nausea, they'll take anti-nauseants or antiemetics, antidiarrheals, for example, to try and control diarrhea, painkillers to deal with pain or disruption. And I think part of the frustration for the patients is, what do they get from us when they come back to us? They are already trying to live their best life that they can. I think we also should recognize that certainly, say, in the US, surveys have shown that in the general population, more than 50% of all food consumed is prepared outside the home. And think about the impact on your lifestyle. So when Dr. Kelly and I have to counsel patients on restricting their food movements, as it were, so they can't eat out very much, that has a dramatic impact on people's lifestyle, leading to isolation, both social isolation and work isolation, for example. So I think we have to balance our futility, let's say, of being able to get people onto a super strict gluten-free diet with real life and the ability for people to function. And I think every week in my clinic, I will have patients such as Dr. Kelly has described who are struggling to be gluten-free despite their best efforts. And it is frustrating, of course, for them and for us that we do not have effective disease-specific treatments to offer them.
Yeah. I have patients who, when they travel or are away from the home for a period, will be sure to bring medication with them, such as an antidiarrheal agent, in case that they have an inadvertent exposure. I also have patients who tell me that when they travel, particularly if they're going to a place where the availability of gluten-free foods is less certain. They will also often bring two suitcases, one with clothing and one with food. Then in the larger suitcases, the food to prepare themselves for their week of vacation. And that really reduces the fun of going away on vacation when you have to sort of stock up with gluten-free foods in advance.
Yeah, indeed, indeed. Marilyn, is there like a general mud among patients that the availability of treatment has not changed and that more research should be done? Are they motivated to participate in clinical trials?
The answer is yes. You know, since 2020, we've been able to have NIH funding for celiac disease research in the US, and that is absolutely because of the patient effort behind that to lobby Congress to understand the seriousness of the disease. Even during COVID, and the Celiac Disease Foundation recruits for clinical trials for celiac disease therapeutics, we've had more than 20,000 patients during COVID attempt to enroll in a trial, and these trials actually even included gluten challenges. That's how serious the patients are about having, if not an alternative to the gluten-free diet, at least an adjunct therapy that will allow them to live their lives. I want to emphasize, this is not about, eating your favorite foods. It's not about, oh, I feel sad for myself that I can't go to this party or I can't travel. It's about trying to get through your daily life functioning and without being ill.
Yeah, thank you.
Yeah, I think, yeah, a lot of the problems in terms of ongoing symptoms derived from small inadvertent exposures to gluten. It's not that somebody orders, a plate of pasta and eats half of it before they realize that it's gluten-free. It's more usually that there's small amounts of contamination, but many individuals with celiac disease are exquisitely sensitive and will develop symptoms just with minor exposures. And so an intervention that could raise the threshold in terms of how much gluten would lead to symptoms would be a huge bonus for celiac patients in terms of their quality of life and their ability to function in the modern world.
Yeah, thank you. Let's dive a little bit more into the clinical details. Dr. Murray, it seems like celiac disease diagnosis has dramatically increased in industrialized nations in the past few decades. Could you elaborate on the reasons for this?
So there are probably two major reasons. The first is that our tools for detection of celiac disease have dramatically improved in the last few decades. Now, most patients are detected by serology blood tests, which are now widely available and often performed by primary care practitioners now around the world. So the tissue transglutaminase antibody test is reasonably accurate and sensitive for detection, and it's often the first step in detection. It has become included by many doctors, even specialists, in some of the panels that they undertake when patients present with different symptoms or syndromes. And celiac disease, while we think of it as a GI condition, it can present to our endocrinologist, for example, with early onset bone disease. It can present to skin doctors with skin problems. It can present across the whole spectrum of medical specialties. So accessibility of an easily obtainable detection test is one of the major factors. The second is the disease has truly become more common. And work done in a variety of populations have shown that if you go back historically and look at old, say, blood samples, for example, there wasn't that much evidence of celiac disease 50 years ago. So the disease has truly become more common. And that is especially marked in young people. One study in Denver has suggested a substantial increase. We're now could be looking at as much as 3% of the teenage population being affected. So, and that increase is continuing predominantly in younger patients, but it seems to be so. So it's becoming more common. The whys of that is probably related to some of the same reasons that allergic disorders and autoinflammatory disorders have become more common over time, whether it's some pervasive change or environment, or there possibly maybe other hygiene hypotheses, other ideas, but celiac disease is, if anything, at the vanguard of that increase in occurrence of these diseases.
And I think there certainly is an increased awareness of celiac disease, as Dr. Murray mentioned, not only in primary care, but also in subspecialty practice, where celiac disease can present to a specialist with something that may indeed not be a gastrointestinal symptom, but from elsewhere. But also patients themselves are more likely to think of the possibility of celiac disease. As awareness of the disorder increases in the general population, it's not unusual for my patients to tell me that they urged testing rather than that testing was provided for them without their urging.
Mm-hmm. Yeah, maybe follow-up question. Villus atrophy, the stunning of the little fingers in the gut, sounds a bit casual. However, these villi are actually responsible for most of the surface area to absorb important nutrients, minerals, vitamins, or other substances. Dr. Kelly, do you have any analogy how much surface area a healthy gut has and how little surface area a gut of a patient with ongoing active celiac disease has? And how does this change in surface area affect the health of patients?
Yes, indeed. To go into a little more anatomic detail, there are indeed villi, finger-like projections that line the entire gut. And these hair-like projections greatly increase surface area. But on the villi, they are so-called microvilli, which can be seen by electron microscopy and further increase the area of the gut. And so for Wimbledon enthusiasts, I can give the analogy that the surface area of the intestine is about 200 square meters, which compares to the surface area of a doubles tennis court, which is 175 square meter. And in the denuding of the villi and of the microvilli in areas severely affected by celiac disease can lead to a 10-fold reduction in surface area, which leads in turn to significant malabsorption of fluids and of nutrients, leading to the symptoms that we've been discussing, as well as leading to malnutrition and nutritional deficiency states.
Yeah, thank you. So there obviously seems to be an increasing interest in developing treatment options for patients with celiac disease. Dr. Murray, when thinking about the different therapies currently under investigation, can you tell us a bit more about the different approaches, please?
So one of the great things about celiac disease science is we understand a lot more about the sequence of events that leads from exposure to gluten to inflammation, to barrier disruption, to destruction of the villi that we've just heard about, to actual symptoms and consequences of the disease. And much of this understanding has led to targets or potential targets for interventions. So interventions have been tried of things like trying to change gluten, trying to change wheat so that it doesn't contain those antigenic moieties. That has proven to be a huge challenge. You just can't change wheat as easily. Wheat has more genes than humans have. So it turns out to be not an easy organism to change in that way. The second is to degrade the gluten either before you take it in or after you take it in has been a fairly common approach that's been tried. And there are investigational agents and studies focusing on this approach. There are drugs, more what I call the more typical biologic approach of trying to interrupt the inflammatory cascade that causes destruction of the epithelium or the lining of the intestine. And there are also approaches that are aiming to try and restore or protect the barrier function of the intestine, are just some of the approaches. And then, of course, there's the tolerance approaches where one tries to tame the immune system's response to gluten. All of these approaches are based on the science understanding of how the disease occurs and the destruction that occurs and what those mechanisms are. Some of them are borrowed from other diseases and basically come in and are tried out in celiac disease because there may be some common elements to the destruction or inflammation that occurs. Several have been in clinical trials. We've already heard a little bit about the enthusiasm that patients have, and we've had very little difficulty filling clinical trials, the enthusiasm that patients have, the willingness for patients to subject themselves to gluten challenges, or what I call the first in human exposures for some of these agents, has been very high indeed. And as Marilyn said, even in the midst of the COVID pandemic, when a lot of people were afraid to leave their homes, we've had patients with celiac disease who willingly volunteered to participate in studies that involve multiple trips to the medical center for participation in trials.
Mm-hmm. And I think these factors have led to a substantial increase in activity in terms of drug development in celiac disease. This was something which really wasn't occurring at all 5 or 10 years ago, but now we're seeing more and more attempts at intervening in celiac disease with the knowledge that the disease is very common, as Dr. Murray was saying, increasingly being diagnosed, and also that we have such a good handle on the pathophysiology of the disease, making targets for intervention readily apparent to many. And so that's something that we really welcome over the last few years.
And I think it's reflected by our regulatory agencies. The FDA has engaged in 2 public meetings to address aspects of clinical trials in celiac disease. They've had a draft guidance. So I think the regulatory agencies are certainly very much engaged and recognize the need for therapies as well, not just the patients, not increasingly the medical community, but also our regulators recognize that there is a substantial need there.
Thank you, Dr. Murray. That's the perfect bridge to my next question. How actually do typical phase 2 and 3 trials in celiac disease look like, and what is the target population?
So the typical target population currently for patients, I'm sorry, Joe, that's your question.
Oh, no, well, basically as Ciarán was about to say, the primary group of need are the patients who have ongoing symptoms. And that could be 30–40% of patients with celiac disease have substantial ongoing symptoms that requires some other intervention. And that is probably the first use case for therapies for celiac disease. And I know, Marilyn, your group have addressed the desire for therapies, the need for therapies in these populations. Do you want to comment on what you've done?
So, the adult population, generally 18 to the age of 70, people who are on a well-controlled diet. So these people think that they are doing the best that they possibly can. They're keeping a strict gluten-free diet, but they're still experiencing symptoms due to inadvertent gluten exposure or for whatever reason, but that would be the general population. And again, when we talk about the 20,000 who attempted to enroll during COVID, you can think of the tens and tens of thousands more who would not step up to a trial, but have to be experiencing the same issues.
And so these patients that we're discussing, which are the typical population now for most celiac disease trials, have so-called non-responsive celiac disease. In other words, their celiac disease signs and symptoms persist despite their very best attempts to follow a gluten-free diet, albeit that probably reflects contamination of their diet despite everyone's best efforts. And in those individuals, both symptoms of celiac disease are occurring, but also signs of the disease will occur, including continued damage to the intestine, leading to malabsorption. And non-responsive celiac disease, depending on how you define it, can affect anywhere from 10 to 50% of patients with celiac disease. And so it's not at all unusual for patients, despite being on a gluten-free diet, to have ongoing symptoms. And the goals of these interventions, these clinical trials in non-responsive celiac disease, are to reduce symptoms and to improve histology. Those are the 2 primary goals. Ideally, the intervention should also be capable of improving quality of life. There is another patient population that has been the target of clinical trials in celiac disease, and that is refractory celiac disease. Here, the medical need is even greater because the signs and symptoms of the disease, as suggested by the title, are even more severe. However, this is a smaller population. And so there have been fewer studies in that population compared to the very large population of patients with non-responsive or continued active celiac disease.
One population we shouldn't forget in the early phase studies, the phase 1 and the early phase 2A studies, it often involves a proof of effect of the drug. And the patients who are often recruited for those are the patients who are actually doing well. And while we think of the patients who have ongoing symptoms as being very motivated to seek out answers, even the patients who are doing well on a gluten-free diet are very motivated to participate in the study because they see the great need for additional therapies. So those trials often involve gluten challenges. And as Marilyn said, we had tremendous enthusiasm for patients with celiac disease to participate in clinical trials. These are patients doing well, not even the patients with symptoms, who came in and gave of themselves during the COVID pandemic to participate in trials that involved giving them gluten to see if the new therapies or potential therapies protected them from the effects of gluten. An important early phase type or design of study to prove the mechanism of effect of whatever therapeutic is being tested.
Yeah, follow-up question here on the clinical trials and trial designs. Which parameters do you think are most relevant to look at to see a benefit for celiac disease patients? Is it histology? Is it symptoms? Is it anything else, or a combination of different aspects? Maybe Dr. Murray, you want to start?
Yeah, so Dr. Kelly already alluded to the fact that one, you have to make people feel better. I mean, that's really key. I mean, there's not much point in providing someone who has ongoing symptoms with a therapy that does not make them feel better. The second, of course, would be to function better. That means, can they re-engage with life? Can they be able to get to work every day reliably? Are they reducing the days that they're sick enough that it interferes with their quality of life or their ability to function? And then the third is, do they survive better? Now, we don't typically think of celiac disease as a mortal disease, but indeed there have been studies that have shown impacts on mortality. And we can't do mortality studies as an outcome, but we very much look at inflammation, and it's now appreciated that ongoing inflammation is not a good thing, not only in celiac disease, but in other inflammatory disorders. The goal to try and control the inflammation or the injury. And so in addition to showing that patients feel better, we really need to show evidence that at least their gut does not worsen or actually improves with therapy. And those two things need to be generally in parallel. You need to get patients to feel better. That's an absolute. But you also need to have some evidence that the intestine is at least stable or improving in terms of the injury. Those would be the two major outcome measures. In terms of the design to achieve this, many of the studies, especially the later phase studies, focus on patients with ongoing symptoms and trying to live their lives as best they can gluten-free, as we've already heard from Marilyn, but who are having ongoing symptoms. Some designs incorporate some degree of gluten exposure, deliberate or planned gluten exposure, and some do not. Again, those are somewhat different designs of study. Often the earlier studies incorporate some level of gluten exposure. It's not yet clear if phase 3 studies will incorporate some level of measured gluten exposure. As we've already heard from Dr. Kelly, from their group, they showed that 2/3 of most patients doing their best in a trial are actually getting exposed to gluten over a 1 or 2 week period. So there is some level of ongoing gluten intake, but those would be pretty typical approaches.
Yeah, to dive in even deeper into this topic, maybe back to Dr. Kelly, what actually is a clinically meaningful improvement for some of these parameters, and how does this translate into a physician's treatment decision?
Well, I think physicians will talk to the patient to ask them how they're doing and are their symptoms improved or disimproved or the same as previously, and how frequently and how severe the symptoms are. We will also do endoscopy with biopsy and look at the histologic changes in the small intestine and compare those over time. But for clinical trials, the parameters that we use are slightly different insofar as we use patient-reported outcomes to evaluate symptoms and quantitative histology, where the actual villus height is measured. So the patient-reported outcome, or PRO tools that are used, have been appropriately designed in compliance with FDA guidelines and have been developed and validated. And there are at least two well-designed and usable PROs available now that are commonly used in clinical trials of celiac disease. What's a meaningful improvement in those PROs? I would say that a 50% reduction in overall symptoms, or a 50% reduction in the most severe of the symptoms on those PROs would constitute a clinically meaningful improvement. In addition to measuring symptoms, these PROs analogous PROs, similar PROs are used to measure and quantify quality of life impact in celiac disease to determine if people are able to, as Dr. Murray say, function better on the medication. And then the histologic changes are measured objectively and quantitatively. And one measure that's often used is the ratio between the villus and the crypt, which is where the enterocytes begin life in the lower part of the mucosa. And typically this is reduced in celiac disease because the villi are shortened and the crypta are enlarged. And this villus height to crypt depth ratio can be measured and can be followed. An improvement of, let's say, 0.1 in that ratio would be, I think, considered to be clinically meaningful.
Right. Going back a little bit to the patient's view and to you, Marilyn, celiac disease patients seem to be well organized. Could you please give us a few examples of how you and other organizations help the celiac community?
So worldwide celiac organizations participate in awareness campaigns. We still have a shockingly low diagnosis rate, although improving. So very organized efforts for awareness campaigns. The other piece is fighting for gluten-free labeling rules so that the current food supply is safe, or as safe as it can be for people with celiac disease. And then the third part is lobbying for funding for celiac disease research. So those are the three components. And in the particular case of the Celiac Disease Foundation, actively participating in the screening of patients for clinical trial so we can speed patients into trial so that we can have a therapeutic more efficiently and effectively.
Mm-hmm. And the celiac support organizations also do provide a very valuable assistance to patients in terms of providing them access to useful, reliable information on celiac disease, as well as access for discussion and debate with other individuals who are following the gluten-free diet for celiac disease. And those components are also very, very useful.
I should say that, celiac.org, we like to say, is the most trafficked website in the world for celiac disease information. But yes, around the world, celiac organizations have robust websites with information for their constituents. Absolutely.
And I think I would also comment that, the Celiac Disease Foundation and others have been, their advocacy, and it's not just advocacy for funding, it's advocacy for awareness, it's advocacy within, say, the regulatory agencies, and they've very much partnered with our regulatory agencies to get their attention on celiac disease, that really regulatory agencies respond to patients and they respond to patient need, and the advocacy organizations have made it very clear to the FDA in the US as well as elsewhere that celiac disease is a disease that is not adequately treated and it requires attention. And it's been, I think, very powerful as an advocacy. I think for any disease, the celiac disease community is about as well represented as any disease has been in terms of advocacy and changing paradigms in terms of what our attitudes are to the disease.
Thank you. Good. For the last couple of minutes of our discussion, and before we open the line for a Q&A session, I would like to switch to Immunic and our Chief Medical Officer, Dr. Andreas Müller, to briefly walk us through the IMU 856 program. Andreas, Immunic recently revealed at the DDW conference in May, IMU 856 target and more detailed mode of action for the very first time, actually. Please remind us of the mode of action.
Yes, so IMU 856 is a small molecule drug modulating the target SIRT6. What is really evident from our preclinical data is that this mechanism of action activates the naturally occurring epigenetic phenotype of epithelial regeneration of the bowel wall. Our initial clinical data set has confirmed that this leads to two important effects. One is the enhancing the quality and function of the epithelial architecture in the bowel, and two, improving the bowel barrier function. And then there's no effect on, or no known effect on the immune system for IMU 856, which we believe is also important for its long-term use.
Yeah, thank you. And then Immunic also recently reported positive data from its phase 1b clinical trial of IMU 856 in celiac disease patients. Please walk us through the trial and what the main outcomes were.
Yeah, we were really pleased that IMU 856 provided excellent proof of concept data on all four dimensions of celiac disease, including bowel histology, patient-reported outcomes or symptoms, biomarkers of epithelial function, and also absorption of essential nutrients. IMU 856 has in particular shown an effect on outcomes that will likely be drivers for phase 2 and 3 clinical studies, as outlined in the FDA guidelines. We have not only seen a protection of bowel architecture, but in some IMU 856 treated patients, we have already seen improvement in the Q-MARSH category, which is the established histological quantitative score in celiac disease, despite the fact that these patients were exposed to a gluten challenge. This was not observed in placebo patients. And for patient-reported symptoms, we were able to show a protection against symptoms deterioration on the first day of gluten challenge, and in most cases, a reversal of symptoms to pre-gluten challenge level with extended treatment during the gluten challenge. This was also not observed in the placebo control arm. We therefore really look forward to further evaluating IMU 856 in the upcoming phase 2 clinical testing.
Thank you. Yeah, let's also not forget about safety and tolerability. What did the trial report on that end?
Yeah, IMU 856 was safe and well tolerated. The most common adverse events found in the celiac disease trial were those that are commonly associated with the disease itself and or the gluten challenge. There were no systematic changes in lab values. In particular, we saw no increase in hepatic or renal events as compared to placebo control. Treatment discontinuations were more prevalent in the placebo arm than in the active treatment groups.
Yes, thank you. You briefly touched on the phase 2 already. Where actually is Immunic in terms of preparing for a phase 2 clinical trial? And have you or will you meet with the FDA to discuss next steps?
So we believe that a phase 2 clinical trial with an expanded dose range and a longer treatment period in an ongoing active celiac disease population that was outlined here is the right next step in the development of IMU 856. And this is right along with the FDA, or what the FDA guidelines actually specify as well. For this reason, we are preparing an IND submission, which we believe is also a very effective way to receive feedback from the FDA on the development program as a whole.
Yeah, thank you. Maybe to look a little bit even more into the future, as we heard, the mechanism of action for IMU 856 activates the natural regeneration mechanisms of the bowel epithelium. This does not sound too specific to celiac disease alone. Does it mean other gastrointestinal diseases may be addressed with IMU 856 as well?
Yes, I think this is a very important topic for Immunic. As you could probably extract from my earlier description of the mechanism of action, is not specific to celiac disease. It does not require ongoing immune stimulation by gluten to provide a differential effect versus a placebo control, we believe. And the concept of IMU 856 can therefore potentially be used in other diseases where epithelial defects in the bowel and impaired bowel barrier function play a crucial role for the disease process. So there's a range of diseases such as Crohn's disease, microscopic colitis, diarrhea predominant IBS, and others that are known to have such disease drivers. Immunic believe that the use of IMU-856 can be extended beyond celiac disease. However, celiac disease by itself will already be addressing a huge unmet medical need, as you heard earlier here, and expected to provide a substantial commercial opportunity for IMU-856.
Yeah, final question, Andreas, please remind us also of Immunic's current cash runway and financing status.
So as of March 31st this year, we had $97 million in cash as per our previous guidance, which provides us a cash runway into fourth quarter of next year of 2024.
Perfect. Yeah, I would like to very much thank all our experts today for this very insightful and interesting discussion. We really appreciate the color and the different around the different aspects and challenges of celiac disease. I would now open the line for a question and answer session to also give the audience the opportunity to discuss with our great experts today. Just a quick intro, if you joined the webcast via the Zoom platform, there are two ways to submit your questions. You can either submit your questions in writing via the Q&A tool of the Zoom portal, or if you would like to speak with us directly, please use the raise hand function of the Zoom portal to queue your question. And I see a couple of hands already, so I will start with Yasmin Rahimi from Piper Sandler. Yasmin, please unmute yourself and go ahead.
Good morning, team. Thank you so much for the really thoughtful comments and really educating us about the high unmet need that exists in celiac disease. Could you maybe help us understand, obviously we're all very looking forward to the Immunic study. What are key considerations that you recommend to the Immunic team in regards to creating a homogeneous population, ensuring a clinical success? So I guess tips and tricks in terms of the study protocol. That's sort of question one. And then question number two is, do patients understand that treatment would be chronic, not acute? Like, do they understand the value of wanting to be on a therapy for long term, or do they want to use the opportunity to just take a therapy, cheat, get a good, gluten meal in their bellies, and then go back to their ways? I would love to hear your thoughts on both, and I'll jump back into the queue to be respectful to my colleagues.
May I take the second part? So this has been the ongoing battle with the FDA. This issue of moral hazard. Will people with celiac disease take a medication so that they can go eat their plate full of pasta? And the answer is absolutely not. This is a chronic, lifelong illness with daily challenges. People absolutely understand that this would be a chronic treatment. So I just want to put that to rest.
I think also the nature of the patients who will be in these trials would support ongoing treatment, because these are patients with ongoing active symptoms. These are not patients who have a once-off episode because of a once-off exposure. These are patients with ongoing symptoms, and so an ongoing treatment is likely to be necessary. As regards tricks of identifying patients who are most likely to be able to respond, I think it would be those who truly have active celiac disease and who have evidence of gluten exposure, either by positive serology and definitely by abnormal histology. However, that said, some of the the patients who may present with symptoms and celiac disease could have other disorders, such as irritable bowel syndrome, in addition to celiac disease. But it's possible that this agent might be helpful to those also.
And I think in addition to that, there are, to those also, the severity of symptoms. You need people to come into the study with a sufficient degree of symptomatology. And so there are now the tools Dr. Kelly already outlined earlier that can help us assess what those symptoms are in a run-in phase. That's also part of the the mix that goes into carefully selecting the right patients to go into the study. Those patients still, of course, have to be representative of the target population. But as Marilyn has said, there's a lot of enthusiastic patients out there who see the need and want to participate because they have substantial symptoms. And they recognize that this is not a short game. This is not for a week or 2 or 4. This is a long-term game in terms of a intervention that's going to be hopefully help them lifelong.
You know, I'll also add that in terms of tips and tricks for trial, it's making certain that your sites are within location of where your patient population is. If you are asking people to come in for repeated visits, if you're asking them to undergo gluten challenge, you need to have your sites located that are convenient for the patients. And that's one of the things that the patient advocacy groups can do, is to help you identify where those patient groups are so that you know where to place your sites.
Thank you very much.
And another part, of course, is that makes these studies more accessible to patients is how you're giving your medication. Is it intravenous? Is it subcutaneous? Is it oral? How often does it occur? Is it something you have to give with every meal? Is it something you give once a day? Those are potential factors that can drive the ultimate utility of a treatment.
Okay, thank you, Yasmin. As the next one, we have Andreas Agerides from Wedbush Pegro. Andreas, welcome. Please unmute yourself. Oh, now I kicked him out again. Apologies. Andreas, please unmute yourself. Sorry.
You can hear me now?
Yes.
Okay, fantastic. All right, thanks for taking our questions and for putting on this very insightful call. So just quick one for the experts here. To get your thoughts around the CERT6 target and what gives you confidence that it would work. Thanks.
Well, I think it's a novel and very exciting approach, and it targets key aspects of celiac disease pathophysiology, and that is the disruption of barrier function, which is a primary event in celiac disease and is evident at the very beginning of celiac disease onset, or even before onset of actual disease in individuals who are predisposed. And the second is improving regeneration of the mucosa, which is, how we diagnose celiac disease ultimately, and it's our ultimate goal to see restoration of a normal mucosa and healthy villi.
Okay, maybe just a quick follow-up, and you kind of touched on a couple of these points in your answer to the previous question. But if this is an available therapeutic, where do you see it when we say where do you see it being used? Is it in conjunction with a gluten-free diet, or is it ahead of? I mean, just some thoughts. Obviously, data will speak for itself, but ultimately, how early do you see it? And you did mention early intervention, but just a couple of clarifying points on that. Thank you.
So I would see this being used in those patients, especially those who come back to us and continue to have symptoms despite being on a gluten-free diet. That would be the first case use. I think it would be pretty obvious, for that group. Potentially that could be expanded depending, of course, on the data. How potent is this in terms of protection against gluten exposures? Would it allow people to have a greater degree of exposure? But that is not yet, I don't want to say that's not on the horizon, but that is not what's on deck right now. Right now, it is those 40% of patients with celiac disease who continue to have substantial symptoms. I have patients every day in my clinic who want to know what drug treatment we are making for celiac disease every single day. And I think studies have been done of surveys of patients with celiac disease. A very high proportion want additional therapies. And as Marilyn pointed out, it's not that they want to abandon the gluten-free diet, burden and all as it is. They recognize how important that is, but they want and they need additional treatments. And I would have very little hesitation in both using a treatment that was found to be safe and effective, but I know my colleagues would, even colleagues who don't even treat celiac disease would probably take it on very quickly as a disease of interest because there would then be a treatment.
I want to add that for the pediatric population down the road, there's such fear among parents about their child's long-term health. So, I can see this as a protectorant in the idea, obviously down the years when we've got experience with the pediatric population, but every parent wanting a treatment for their child, symptom or no symptom, because of that fear of what the long-term health is going to look like, and because they can't control their child's diet when they're out of the house.
Okay, great. Thank you for that. And I'll jump back in the queue.
Thank you, Andreas. We have 2 questions coming in via the Q&A tool. I will just read them. The first one is, could study designs discover effects and other indications in the same single upcoming phase 2 study, similar to the concept of a basket study in oncology? I'm not sure who takes this.
This is Joe here. So generally, for many of these studies, we exclude patients who have other substantial autoimmune or inflammatory diseases. So generally, they're excluded to avoid confusing the picture, especially the symptom picture. So for example, if the patient also had Crohn's disease as well as celiac disease, they would be excluded from this phase of study in order to try and keep the primary outcome measure and the disease focus clear. That doesn't mean that there might not be other things, perhaps psoriasis, for example. Things that have, even though they may not be a gut disease, they may actually have their genesis within the intestine. But of course, safety is always paramount when it comes to patient selection. So I'm not sure how much of an opportunity there will be to make those discoveries. The second, well, that's the first question. I'll answer that. I know you had a second question too.
Yes, I have another one. How well are results from phase 1b studies in controlled patients undergoing gluten challenge thought to translate into active patients?
Mm-hmm.
And Dr. Kelly, do you want to have a go at that one?
we don't have a huge amount of experience in terms of phase 3. There really has only been one phase 3 trial in celiac disease. But in general, we believe that a gluten challenge study is a very good initial proof of concept approach in order to demonstrate that an agent can be effective in avoiding the inflammation and injury that results from gluten challenge. The big question, of course, is will that translate ultimately into successful phase 3 registration trials? Yeah. So I can't answer that yet.
And there, I think patient selection, that is selecting the patients who have got ongoing disease likely to be associated with gluten exposures, are the population where that will translate the best. However, agents that can improve integrity or that can reduce inflammation themselves may still improve a damaged intestine. And we know there are patients who have damaged intestine despite doing their best on a gluten-free diet. And it's not always clear that they're getting obvious gluten exposures. So I wouldn't discount that as a potential, population that could be benefited.
And I may want to add what Dr. Murphy said, that and we have reported it when we reported the data from our phase 1b trial, is that despite our best effort to really enroll well-controlled celiac disease patients into this gluten challenge study, more than half of our patients in the active treatment group, for example, was in Q-MARSH categories that would qualify as ongoing active disease population. And that really shows that sometimes symptoms and the histology don't go hand in hand. But I think that also makes our phase 1b data, we believe, more applicable to the phase 2 population. But of course, we will screen for the ongoing active celiac disease patients.
Yeah, thank you. I know we are slightly over time, but we have one more in the queue. I would like to give Matt Kaplan from Ladenburg the chance to ask questions as well. Hello, Matt, please unmute yourself.
Thanks, Jessica, and thank you to the panel for a great discussion on celiac disease. I guess for the panelist, can you provide us with your overall impressions of the proof of concept phase 1 data that were reported recently? and your interest in being involved in the next steps of the drug's development.
This is, I will come to this first to say that, I thought of this agent and this target as being primarily related to barrier integrity and restoring barrier integrity. However, the data from this study suggests that the effects are much broader than that. We've had effects on absorption, improvement of absorption. We've got regeneration, which is, I think, probably the first time I've seen this for an agent. So I think the effects are broader than just restoring barrier function as a simple barrier function itself. So that makes me particularly excited. Of course, safety is another attraction, but also the fact that it's potentially a once-a-day oral medication that could do this, I think, is also attractive. It's doesn't have to be tied to every time you eat. So I think as a physician, I like to be able to prescribe something like that. And ultimately, as a trialist, that's a treatment paradigm that's easier to execute.
So I agree with Dr. Murray regarding, the ease of use of the agent. The safety is obviously key to demonstrate that it's not only effective but safe. But I was impressed by the efficacy across multiple parameters. It wasn't just symptoms, it wasn't just histology. There's also improvement in absorption. So that's very encouraging and sort of encourages future development of the agent.
Okay, that's very helpful. Thank you. And then I guess maybe a question for Andreas. Can you talk a little bit about the next steps in terms of the timing of the IND submission and the start of the phase 2 study, and then also your current thoughts on the doses for phase 2 that you're going to explore?
So I think we haven't given more specific guidance on timing, and so I have to stay within what we have guided publicly. What we had said is that we want to expand the dose range. I think we, of course, when we choose the 2 doses that we investigated in this phase 1b study, we really had no really good guidance other than translating it to some of the preclinical experiments and what the concentrations are needed and so forth. But we were kind of, both of these doses that we used in the phase 1b trials were in the active dose range, which was very encouraging. But we also saw that the higher dose in the 160 milligram dose in general had better outcomes, numerical outcomes in this trial. So that also leaves the question whether that's already the optimal dose. So I think we will likely want to test a expanded dose range in the phase 2 study.
Yeah, that's helpful. Thanks for taking the questions.
Thank you, Matt.
Thank you, Matt. All right, this actually concludes our question and answer session and also our roundtable today. I would like to once again thank our wonderful experts for taking time today to walk us through celiac disease and the very high unmet medical need in more detail. Also, thank you to Andreas for being with us. Wish everybody a nice morning and afternoon, a good day. And the event has now concluded. You may now disconnect. Bye-bye.
Yes, thank you, everybody.
Thank you, everybody.
Bye-bye.